Good evening. This is the Clinica London Academy meeting. We hold this regularly about 8 times a year, and it is a hybrid teaching. Tonight we've got Mr. Minak Bhalla. He is a consultant glaucoma and cataract surgeon, and he works at the Royal Free Hospital and at Clinica London. We have people here in the audience. They've been here for a while having little bites to eat. It's a beautiful summer's evening, so thank you very much those at home who have also joined us. Please feel free to ask questions through the Q&A. We may answer them as we go along. If not, they will all get answered at the end. It is interactive teaching session. For those of you who are optometrists, it has a GOC number and you can get some interactive points for attending. Welcome to Mr. Minak Bhalla. Thank you.
Thank you, Jane, and welcome everyone from home and those that have attended. As Jane mentioned, my name is Dr. Minak Bhalla. I'm a glaucoma and cataract surgeon, and today I'm going to take you through a little bit about glaucoma and cataract surgery and how it impacts patients' glaucoma. A lot of the time when I learn about my own cases, I learn through patient experience. So I'm going to try and do that with you guys as well and give you examples of patients who have had surgery and the impact it's had on their lives and on their outcomes as well. So these are my financial disclosures. So what do we aim to gain from today? Well, one of the things that we're going to hope to gain is to see what indications there are for glaucoma surgery and recognize some of the common types of glaucoma surgeries that I perform and that are out there that other glaucoma surgeons might be performing as well. What's their impact and what kind of common postoperative findings we look out for and how this can be recognized in the community as well, which is really important because this is going to be a team and collaborative effort when we're managing these long-term patients in our care. And hopefully I can build some confidence, especially with the optometrists out there who are tuning in at home and here as well. So what we do know is that glaucoma is a condition that's growing and is becoming a big burden on the ophthalmological workload. We will find that as our population gets older, more and more patients will be diagnosed. With research, our technology is so much better in recognizing those that have glaucoma. So again, we may see more referrals coming in and we may be able to pick up glaucoma a lot sooner. We know that a lot of research and funding goes into glaucoma as well. And we've seen landmark studies being done throughout the years, which have had a real big impact on how we practice glaucoma. And the reason I've put this table up is because it shows you that these studies have shown that actually surgical intervention can have a great deal of impact, positive impact on glaucoma patients, whether that be invasive surgical techniques or even laser. When I practice glaucoma, and I'm sure a lot of you are familiar with this diagram, a lot of the time when patients have suboptimal pressures or have pressures that are causing damage to their optic nerve, they often get started on drops and there's a ladder of treatment. And this is what I really try to show patients, that they are on a ladder of treatment and that any time that I look to intervene is I'm trying to bring them down that ladder of treatment. And initially when they're on these drops, I try to offer them laser or minimally invasive glaucoma surgery, and I'll show you some examples of that to bring them down that ladder. Now, we know that NICE guidelines and through the LIGHT trial, both in the UK and North America, that SLT is excellent and it's first line. So patients who present to us, we offer them both drops or SLT, and depending on what they prefer, they can have either arm of treatment. I often tend to try and influence a patient to have SLT because we know that from the studies alone and from the patients I have offered SLT, one treatment can actually leave them off using drops for a number of years. And that's amazing because it's so much better than having to take drops every day. So what kind of treatment do we have? What kind of surgical treatment do we have? Well, these are some of the examples of some of the angle surgery that's offered. Now, there's a few things here that are no longer used, but certainly you may have heard of a hydrus and you may have heard of eye stents. And these are small devices that we use in the drainage pathways to help keep the pressure low. And often these can be done alongside cataract operations to help patients come off drops or to stop them needing more drops later on. When drops are not enough and they're still progressing, then often they need slightly more advanced surgical interventions. And these are some of those examples. So you can have smaller tubes being put in to drain the pressure. You have the more traditional trabeculectomy, which I like to say is like a valve that we create on the eye to help release the pressure. And then you have more advanced, bigger tubes to help release the pressure as well. And again, there'll be examples of all of this in my presentation. So I'm going to start off by giving you a case study of my first patient. And this was an 87-year-old Caucasian woman who presented. She had been previously diagnosed with primary open-angle glaucoma in the left eye and ocular hypertension on the right. And she was on Ganfort for this, and she was also symptomatic with her cataract. And these were her fundal images. So you can see there's an asymmetry between the optic nerves, with the right showing a slightly more glaucomatous appearing nerve. And you can also see that there was, sorry, the left. And you can also see that there was a progression in the visual field as well when we compared all the visual fields that the patient had over the last few visits. And there was this inferior arcuate which was getting worse. So the patient had a symptomatic cataract, was on Ganfort, and the glaucoma was getting worse. So I used this opportunity to tackle both the glaucoma and the cataract at the same time, two birds with one stone. And I did this with a cataract plus a MIGS operation. And in this video, you're going to see a very edited and fast version of a cataract operation that I did. And we create small micro wounds, which you may have all seen either, if you've visited the OR room in the past or if you've seen YouTube videos. And we remove the natural lens within the eyes by opening up the capsule. And then we use an ultrasound machine called a phacoemulsification to not only break down the lens, but to eat it up. And that's what you'll see here as well. So often this operation takes roughly between 15 and 20 minutes. This is, like I said, an edited version. So once we've removed that, we try and maintain the natural infrastructure within the eyes, and then we insert the lens which goes in. So that's a cataract operation. So like I said, two birds with one stone. So what do I do at this stage? I'll rotate their eye and we get a good view of their drainage angle. And this is where we insert that special stent. So in this case, I'm going to insert a hydra stent. And this is a stent that will keep open the drainage angle and it will act as a scaffold to allow the pressure or the fluid within the eye that creates the pressure to be low. So that goes in very nicely and it's tucked away. And then I finish up on the operation. So what does that mean for the operation, or what does that mean for the patient's outcomes? Well, you can see, firstly, the cataract itself helps to improve their vision and helps to take away those symptoms that they were getting. And more importantly, you can see that there's a positive effect on the pressure. So at least on the left eye where the stent was put in, the pressure dips down quite nicely. And what this means for the patient is that we can start taking the Ganfort off. So you can either break it down into them taking just a single agent because Ganfort is two drugs in one bottle, or you can try and stop the Ganfort altogether and see how they respond to their pressure. And that's what we did. So for patients who have this, to take them off that burden of drops is super helpful. And then we're going to review this patient again to see how they do with their pressures. So for MIGS, for these minimally invasive glaucoma surgical stents that we use that are out there, I tend to use something called a Hydrus. And the reason I like the Hydrus is one, the data behind it's very strong. It has a threefold sort of mechanism that is advertised. It bypasses any resistance that might be in the drainage angles. It keeps it open, and it obviously allows there to be a larger surface area of use because it's slightly longer. Like I said, the data is pretty good, and you've seen that one of the landmark studies that was done for the Hydrus, a lot of patients had very good visual recovery, and a lot of them actually were medication free as well afterwards. So, what does this mean for you in the community? Well, actually, preoperatively, if you're seeing patients who are on a single agent, if you're noticing that the glaucoma may be getting worse and they're symptomatic of having cataracts, then actually from your point of view, you could begin to educate them or think about referring them on to not only have their cataract operation, but to have these special stents on the side as well, because that can make a world of difference to this patient. And this is something you can do, obviously, at Clinica, you can refer on to us. And post-operatively, it's always good because whilst a Hydrus doesn't cure the glaucoma, it certainly does slow it down. So just remember that this is all about reducing that burden of drops and slowing down any glaucoma progression and stopping them from needing more advanced surgical interventions later on. My next example is an example that I actually tend to use quite a lot because it was an example that had quite a dramatic outcome. And this was a 76-year-old Asian woman who had initially presented to my NHS clinic, and she was deemed to have a suspicion of glaucoma. She was a myopic, no other family history, and no other ocular history. And back in 2023, her vision was 6/12 in one eye, 6/7.5, but her presenting pressures were very high at 30. Angles were open, no other comments were made about this, and the disc was deemed to be glaucomatous. And she was diagnosed with glaucoma with no other specific subtype being allocated or to the patient. And these were the visual fields. She was started on a prostaglandin analog and the pressures responded. So she went down to 18, which was really good. So we have a really good diagnostic network here at the Royal Free. So when patients are stable, they tend to get sent to these diagnostic hubs. And she was deemed stable because she had responded and she was sent there. 4 months later, she had another high pressure reading and she was sent back to face, and the patient was understandably getting very worried. We had told her that the pressures had now been treated, but what had happened? Why were her pressures going up again, despite her being very compliant with the drops? So she was seen privately, and her pressures had risen even further. And then one of my colleagues who saw her actually diagnosed and labeled her as a pseudo-exfoliative glaucoma patient, and more drops were given. Then, July, her pressures came down, and she was advised to continue to do what she was doing. So over the next few visits, she was actually seen by one of our hospital optometrists. And on the first visit, we had noticed that the vision had dropped a little bit, but the pressures were fine. These were the OCTs. Now, for the people that are here, is there anything you'd be worried about when you see this, or any of the data I've given you? Does anything concern you at all?
Anyone here in the audience like to use the microphone?
It seems to be on one side. Loss of vision seems to be on one side,
Yeah,
both eyes.
yeah. It is a little bit more asymmetrical. One side is getting a little bit more worse. The OCT is showing a floor effect that it's thinned so much, and that is rather worrying. And these are the visual fields. So that defect, which I showed you when they initially presented, looks a little bit worse now. And actually there's probably some degree of progression. So when this patient was seen, they were checked if were they taking the drops? Yep. Had they told their DVLA about this condition? They had. And that was it. They were told to continue because the pressures were deemed normal and come back in 4 months. So they came back, and if you notice that the vision had dropped again in the right eye, pressures were creeping up. That disc looked more cupped. And this was the visual field. Is there anything on this particular visual field that's concerning you?
When you were showing the OCT,
Yes.
the thinning was on the nasal side in one eye and the temple in the other. That can come from something post-chiasmal.
Yeah, that's a very good. So definitely. So one of the very important aspects and one of the very important things to remember in glaucoma is that we can get very fixated on the optic nerve being damaged by glaucoma alone, and we can forget about these extra or neurological causes, and sometimes they can be missed. Luckily for her, from reasons that were not linked to her visits to us, she had her CT scan, which was negative, and that was documented. So we weren't really worrying about that, but that's a very good thought process to have, and always think that could this be something other than the eyes, okay? Because that can obviously be life-threatening, and we can really save someone's general health, just through a simple investigation like a CT scan. One of the things that worried me when I was reflecting on this case and looking back at her history was that the defect was obviously very dense, but it was beginning to involve the central point of fixation. And the issue with that is that vision tends to drop a lot quicker. So when people think about glaucoma, it's this peripheral loss of vision with the central vision being maintained until the very end. But sometimes you can get quite advanced glaucoma where the central bits of the vision are affected as well. And this is the OCT again, showing a few more changes, but because of that floor effect, sometimes you can't really appreciate that on OCT. But my colleague who had seen this patient said stable visual fields, pressures are within normal limit. Perhaps the visual reduction was due to macular degeneration, and review in 4 months. So the vision had now dropped to 660, and this is around about the time I was sort of taking over the care of this lady. And when she came to me, her pressures had shot up to 38. Vision was now 660, and her pupils were not responsive as well. And the discs, well, we know they were very cupped, and that defect in the middle was getting a lot worse. And you can see the trend on our EPR. Vision was going down, pressures were rising up in both eyes. So I had a frank discussion with the patient, apologized, and I said, look, this is probably irreversible damage. We're unlikely to recover the vision that you've lost. Put her on all the medication that she was on, plus Diamox, and listed her for urgent surgery. She was understandably quite upset. So at this stage, I guess I had two things I had to worry about. Number one, the patient was on a tablet called Diamox, acetazolamide. Now, this medication can lower the pressure quite effectively, but actually has a lot of side effects. So when I do use it, I use it as a temporary measure. Now, her vision had markedly reduced on that side, but I couldn't leave her on that tablet long term. So I wanted to get her off all the medications, and I proposed this particular treatment. What I was also noticing was that her left eye pressure was also rising, and so she was heading towards the same direction as her right. So I had to act quickly, and one of the surgeries I proposed was putting this small mini tube into her eye called a PreserFlow. And this mini tube drains the fluid from the eye around the eye. And actually, it's a pretty good surgery. It's often compared with the traditional and well-known trabeculectomy. It doesn't do as well as a trabeculectomy, but one of the strengths of this PreserFlow is that the likelihood of any post-op complications is slightly lower from the trials that have been done. And again, this is a very quick video, very edited video of me placing this tube into this lady's eye. And once that drainage path is created, the tube's simply inserted and then sutured down, and then the conjunctiva is brought over the tube so that the fluid drains and forms a reservoir underneath the eyelid. And fortunately, the patient had one eye, responded very well, and then I did the very same surgery on the other eye as well. And this is me just closing up the conjunctiva. And you can see that the vision had reduced and sadly remained low. But my worry was that the left eye may head in the same direction, so I acted very fast. Once the right eye was complete, I went on to action the left eye. And this is what happened. After the intervention, you can see that the pressures plateaued. They actually they remained low and they remained in the safe parameters. And you can see they had this sort of peak and troughs throughout her treatment. And each peak was slowly damaging her optic nerve more and more and more until her vision was affected. So in March, one of her visions, she had lost all sight, as we knew. The left eye we maintained, the pressures were excellent. More importantly, she was off all drops and treatment, and she had stable fields with no other concerning features. So she's now under monitoring and keeping a close watch on her. It's her only eye, and I will probably have a very low threshold to intervene to restart drops if I find anything changes. Pseudoexfoliation. This is one to watch out for in the community. And the reason being is that patients can have very high pressures, and actually they have this diurnal variations as well in their pressure. And this can at times, leave us a little bit stumped because they'll tend to come to our clinics with normal pressures, but actually they could be having this at home as well. And they can have severe optic nerve damage as well. And the presenting IOP is often the strongest risk factor of their prognosis and how they'll do. So again, how does this help for you guys in the community? Well, anyone that has advancing glaucoma that may have this subtype, is intolerant to drops or has having compliance issue with drops, then again, it's worth referring them to consider some of this bleb-forming surgery like having a PreserFlow or a trabeculectomy, because that can again take them off the drops and protect their vision from further damage. And post-operatively, if you are going to be sharing the care with the hospital, because sometimes with the huge capacity issues, patients' appointments get cancelled, and you may get patients coming into your into the opticians to have a regular eye check, and having a look underneath the eyelid and seeing that bleb, you may be able to pick up any early signs of infection. So if it's red, if they're complaining of symptoms and they're getting photosensitivity or their pressures are rising, then it's again a really good time to contact either their surgeon if they've had surgery before, or referring on to, say, Clinica, where we can have a look at the patient and advise accordingly. This next case is a patient who has normal pressure glaucoma. So this particular subtype of glaucoma can be quite challenging to treat. They can have very advanced, they can have very severe visual field defects, and their pressures are always within normal. So we normally have to push them to have quite low pressures. And often with this pathophysiology, they often have other vasospasmodic issues as well. So they can sometimes be suffering with migraines and Raynaud's, where their blood vessels contract in a slightly more abnormal way, which is one of the reasons that they end up getting glaucomatous defects, because the blood supply to the optic nerve is also impacted. But what we know from research is that we still need to lower the pressure for these patients in order to protect them from further damage. And when this patient came, they had already been on Fixapost, which is a combination of latanoprost and timolol, and also dorzolamide, so triple therapy. They also had a background of hypertension and high cholesterol. And as I mentioned, a lot of my learning is done through my patient experiences. So when I see previous cases, I always try and remember, what did I learn from that? And one of the things that worried me about this case was that central defect, the central fixation that could be impacted. And based on this, I spoke to the patient to say, look, you're on triple therapy at the moment. It doesn't look like it's doing enough. Looks like it's getting worse. But more importantly, it's affecting the central point of your vision, which could actually have an impact on your visual acuity in the long run. So I proposed surgery. Now, what we know for these patients is that trabeculectomies are probably the most effective surgeries because they really help to keep the pressures quite low, okay? Whereas some of the other ones, the pressures tend to rise or can be a little bit higher. And in trabeculectomies, we can get single-digit numbers, which is super important in normal pressure glaucoma. This is a trabeculectomy, one of the oldest glaucoma procedures around. And what we do here is we fashion a flap, which I like to think of as sort of a valve that releases the pressure. And we do this by creating enough space underneath the conjunctiva, which is through this dissection that I'm doing. And then in a moment, you're going to see me creating a small trapdoor, which is where you enter into the eye, and that's where the fluid that creates the pressure will be released from. And we put stitches on here so that not too much pressure is really, not too much fluid is released that the pressure drops, but only an amount that is safe for the eye as well. And at the end, I'll show you, because once you've tightened these stitches to ensure that the trapdoor isn't widely open, you test by putting some fluorescein on there to see that the fluid is actually coming out. So every time the fluid builds up, it will release a little bit. And that constant release of fluid will keep the pressure at a very safe level for this particular patient. I think we're getting a question from online.
A question online about the shunts.
Oh, yeah.
Are they easily available on the NHS at an early stage or only in private care?
So it all actually depends on your foundation trusts, but all these shunts are available on the NHS and they're all done on the NHS as well. In terms of how quickly they're available, this obviously does vary from different parts of the country and what capacity and surgical capacity there is at a trust near you. But generally at the Royal Free Hospital, we try to, accommodate patients who are at high risk of visual loss to try and get them done urgently. We have a very good unit there where we have more than one glaucoma surgeon. So if we need a patient to come in for surgery urgently, we can manage that. But all of these should be available. I just can't comment on how quickly they'll get it.
And do certain glaucoma surgeons have preferences to some shunts rather than others?
Yeah, a lot of it's based on experience. I'm trying to show a little bit of the evidence behind why certain shunts are done for what reason. But if a patient, so trabeculectomies are generally something that's taught to all glaucoma surgeons. And it's like I said, one of the oldest and more traditional surgeries. The newer stuff, I think if you've been taught it, you may be able to do it. But if you haven't, then it may be something that you may need to refer elsewhere for.
I think one thing that struck me about you, Minak, is because you're a young glaucoma surgeon, if I may say so, you've actually been brought up with shunts. So they're like normal for you, which is fantastic. Yeah. We have one more question and then we'll stop interrupting you for a little while.
Okay.
Is PXF more common in certain ethnicities?
Yeah, that's a great question. And yes, it can be. So North European, Scandinavians are more likely to develop PXF. And so you should always, when assessing, looking out for those signs and symptoms. So if you have those dustings on the lens, or if you have, pigment in the anterior chamber, if you're seeing iris transillumination, or you're doing a gonioscope and you're seeing a very pigmented angle, then your suspicion should be raised that is there some form of pseudo-exfoliation or pigmentary version of glaucoma? So that's really important. Yeah, good question. So with this patient who had their trabeculectomy, one of the difficulties when you have these very invasive operations is that often the follow-ups can be quite frequent. And that's something we warn our patients about, that they'll probably have to see me almost weekly for the first sort of 4 weeks. But once they get past that critical phase and actually the pressure staying under, within the parameters, then we end up getting to a level of stability, and then the intervals between each appointment increase slowly and slowly. And with this patient who ended up doing very well, 7 months post-operative, their vision was very good, pressures R11, no drops, and all the tests were stable. So we managed to really get a hold of their glaucoma, get them off the medication, and stop that from progressing any further and preserve that vision before there was any further damage. And again, as mentioned before, sometimes with the capacity issues within the NHS, patients' appointments do get cancelled, they do get missed, and sometimes very hard for them to get back into the system. And sometimes you'll find that these patients walk into their high street optometrists, and when you're having a look, doing a refraction, and they tell you about any glaucoma surgery, have a look at their blebs. Look out if they complain for you signs of pain or reduced vision. Look at their bleb and see if it's injected. Is there inflammation in the eye? Does the bleb look like that image or does it look like this image? And if it looks like the one on the right, then that should be ringing alarm bells whereby you're thinking of either referring in to their trust or speaking to their surgeon who operated on them. And if that's not accessible for whatever reason, then thinking about referring them to another person who may be able to manage this. Because sometimes if you recognize early signs and symptoms of a bleb-related infection, you can really protect and actually save their sight, because once that infection kicks in, their vision can drop quite quickly and can be quite damaging. So always look out for that when they do come in. And my final case is a 77-year-old gentleman who had very advanced open-angle glaucoma, and their pressures had risen to 30 and 28, had previous trabeculectomies, and actually, as a consequence of the trabeculectomy and how quickly it was done and the subsequent follow-ups, their vision had gradually deteriorated in one eye, leaving them with only one-sided vision. And he was very anxious because actually when I saw him and looked at his test results, I had to sadly tell him that his only seeing eye was also progressing and it was getting worse. And he was already on maximal therapy. So we were really left with no choice but to talk about further surgery. So I added a fourth-line medication in the form of iopidine, and I discussed inserting a larger tube, an aqueous shunt. And studies in the past, like the TVT studies and the primary TVT study that compared tubes and trabs, showed that tubes were a very effective form of intervention. And actually, at 5 years, they tended to do very similar to trabeculectomies, and actually, tubes did a lot better, especially in patients who had had previous eye surgery, whether that be trabeculectomies, so glaucoma surgery, or even vitreoretinal surgery in the form of detachment repairs. This is what these aqueous shunts look like. Now, this is a Paul tube, which is one of the more commonly used tubes at the moment, and it's a newer aqueous shunt, but perhaps the ones people may have heard of are the Barvelts and Armids, which are used as well. And they drain the fluid within the eyes and they drain it into this capsule that forms around the plate of the tube. And this is just a comparator between the lumen sizes of those tubes. So you can see the PreserFlow, that small microtube that I used earlier in that lady who lost her sight, how small that is compared to the Paul, which is slightly bigger, and the Barvelt, which is a lot bigger. And I guess just to showcase what this surgery involves. And actually, this surgery is probably a little bit more technical than the previous surgery. It involves us actually even getting the eye muscles involved, because we tuck that plate into the eye muscles before suturing it down. The next few steps are probably not too dissimilar to the stuff you've seen, where we create an entry point into the eye and the tube is inserted into the eye so it can drain that high pressure. And we use sutures to suture down the plate onto the eyeball itself and keep the tube sutured down, and so it's not mobile at all as well. And we can check if it's flowing by looking at the back and seeing how much fluid is coming out, and that can be seen live during the operation itself and gives us an idea if the tube is functioning very fast or very slow. And these are just the final few steps where we secure the tube, as I mentioned before, and start closing up. Yeah.
A question from people online. How long do MIGS or tubes last?
Yeah, that's a great question. So MIGS, when you're putting the smaller stents in, all depends really, but they can last a while. So if the patients are in the early form of glaucoma, then, and we manage to do their cataracts and put a small stent into the drainage angle, then we bring them back to, to the floor where the ladder is. Then if they restart drops as their pressures rise, we can delay the prospect of any more invasive surgery many years down the line. There are some types of glaucoma that are they can be very advanced and very aggressive. And in those cases, these stents may not last, but they may not be the right choice in those particular patients. If you know that you have a patient who has a very aggressive, fast rate of progression of glaucoma, then you should really be thinking about slightly more bigger operations like your tube operations, because those smaller MIGS stents aren't really going to do much at those stages. And for this patient, as you can see, once they had, so that little period was when they were having drops, and we weren't quite managing to keep the pressure down. It kept on rising again and again. But as soon as they had the surgery, the pressure plateaued. And actually, we were able to control the pressure and stabilize the visual fields. And again, looking at this patient 9 months down the line, the vision again was stabilized. Patients off all the drops in their only seeing eye, and then they had their cataract operation more recently, which was unremarkable, and they've been monitoring. And I wanted to really highlight this particular feedback that I received from a patient who had a tube operation. And actually, these operations are pretty advanced operations. They do take a long time, and they can be quite nerve-wracking for patients. But you can see the impact that they can have. And the feedback is that actually the patient, after having this operation, was able to return to their normal quality of life, to their normal day-to-day life, and improve their quality of life just from having this operation. So it's speaking to the patients and giving them that confidence that this sort of operation, whilst it may be very difficult to begin with, may take a lot of their time, both physically, emotionally during the surgery, and then to see their surgeon every week, actually in the future can really help them with not only controlling their glaucoma, but getting off their drops and improving their quality of life, which is very nicely highlighted by this patient. So what does this mean for you? Well, actually, when you see patients who've had previous glaucoma surgery, always look out for the tube. Often on the slit lamp, it looks a little bit like that. So the bigger tubes you can see usually around the 1 o'clock mark, because they're normally placed in the supratemporal region of either eye, normally. And always look at the cornea. If the cornea is struggling or is becoming a bit more hazy, then sometimes that could be due to the tube, and that will warrant a referral as well. And if the pressures are rising, then again, we have to start thinking about, is this tube still functioning? Because the patients who often require the bigger tubes often have the more aggressive glaucomas. And it may be that after a while, the tube doesn't do enough. And again, they may need to be started on drops and may need to be referred in to their glaucoma doctors. And similar to the trabeculectomies and the smaller PreserFlow tubes, always look out for any infections and inflammations that may arise, because again, early recognition in the community can really help save their eyesight if they're going to develop a post-operative infection. Always continue to monitor their OCT in the community, especially if they're no longer getting any appointments in the NHS due to constraints, and have a low threshold for referral. And the key learning point here is that it does control the pressure, but we can't stop the glaucoma progression in some patients, and monitoring is absolutely key. So these cases show you how surgery can be an important intervention in managing glaucoma. And actually, when we work with the community, we will not only help raise awareness about all these other options that patients have, because some patients may feel that having glaucoma will inevitably lead to sight loss later on, or they'll only be able to take drops for the rest of their life. But that's not true. And I've shown you the examples of that, that actually we can do a lot more beyond drops to get them off drops. And I'm a real big advocate of trying to get patients off drops, because you've probably all seen patients who have been on chronic drops, having those long lashes, those reddish eyes, and perhaps even depigmentation around the skin. And getting them off those drops can really help, aesthetically help them as well. Monitoring is always key, even when they have this surgery, because none of these operations are a cure for glaucoma. Sadly, we don't have a cure, but what we do have now is more and more technology and devices that help slow down the progression of glaucoma. And the slower we can make glaucoma, the less chance there is for patients to lose their sight. And finally, it's really important that we always choose the correct patient who requires this intervention, because intervening at the correct time can have a real impact on their quality of life. Thank you so much for listening.
Well, thank you very, very much, Minak. I also thank the audience here and those at home. We're going to open this up to question time in just a sec, but I want to thank Scope, who have actually helped to support and sponsor this educational event. I forgot to say so at the beginning, so thank you to Scope out there who couldn't make it here tonight. So you've talked about treating and managing, and you said we can't cure. When do you think we're going to be able to get to a preventive stage for glaucoma?
I think we're there already. There's a lot of, research out there. There's a lot of technology where you are genetically profiling patients and finding those at high risk and treating them, preemptively. And we have our very own Anthony Kawaja at Clinica, who does a lot of research around this and identifies these patients. And that is the key preventative cure, actually. If you know there's a strong family history and you can find someone who has a higher risk, you can perhaps intervene early enough that they never develop any changes.
So it's big data and looking for risk factors.
Correct, yeah.
Great.
Yeah.
Questions from here?
So in regards to tube surgeries, are there any patients where it's a contraindication to use surgery, or lifestyle restrictions or limitations where it may not suit their career or job?
Yeah, absolutely. So a lot of these things, there will be certain patients it's just not appropriate for. Sometimes your hand is forced, so despite their jobs or their lifestyle, if they have progressive glaucoma and the drops aren't doing anything and you've tried laser, sometimes you're heading towards surgery, then it's always about picking the right sort of patient to do the surgery on. Specifically, it's very hard to pinpoint, but there will be specific contraindications for each patient. Often for my practice, if patients have had surgery, I tend not to do anything that forms a bleb. So if they've had previous vitreoretinal surgery or cornea surgery, I won't really be doing a trabeculectomy or a PreserFlow. I tend to move straight on to the shunt, because what the research has shown us is that those surgeries fail very quickly if the conjunctiva has previously been manipulated. And then rather than put the patient who may already be nervous through 2 successive operations, if that one fails and then they have to have the aqueous shunt, I usually just jump straight to the aqueous shunt and then just obviously counsel them about that.
Is contact lens wearers, is there a contraindication to after the surgery or?
Yeah, so it's not a contraindication long term, but there are some surgeries where usually it's encouraged for them to wear glasses afterwards. Because remember, a lot of these surgeries will have patients who will have sutures in them, and we don't remove those sutures for about 4 to 6 weeks until after the operation. So any contact lens they have may not work for them. And it may be that they wear it in the other eye, and in the left eye, they just put some glasses. There are ways around it. Yeah. But after they reach that stability, they can often return back into getting a new prescription of contact lenses.
Minak, we have a question online. Are the materials used in microstents MRI safe?
Yeah, excellent questions. They are, yeah. So often the metals that are used, so the hydrous, the one I showed you, and the one I use in my practice is made of a material called nitinol. Nitinol is something that we use in aerials, and it's a malleable metal, and actually it's not contraindicated in MRIs. And it won't bleep when you go through airport security either.
As an oculoplastic surgeon, one of the complications of some of the glaucoma drops is orbital atrophy with a sunken upper sulcus. And can you just give a mention about those drops? I'm not against drops for glaucoma, but it's very lovely that you've got so many other surgical options for them, which are giving them long-lasting effects and getting them off some of these drops, which can have some quite unpleasant and scary side effects.
Absolutely. And it can really change someone's appearance and really change their self-confidence when they are on drops. And I think as more and more people are becoming aware of glaucoma, sometimes patients feel that it's inevitable that they're just going to have to be on these drops. And that was really the idea behind this talk, just to showcase all these other options that are available. And patients don't have to be, resigned to only being on drops for the remainder of their life, because there are ways of getting them off it. And we know that from drops, actually patients can still progress. And we know from the data that surgical intervention can slow that progression faster than drops can long term.
There's a super question here online. Is there any age limitation for surgery?
Yeah, that's a good question. No, there isn't. No age limitation. I think if a patient is willing, you can really help them at any stage in their life. And I've had patients who have been approaching 90 who are on all the drops possible and are even going on to being on the tablet, which could harm their general health, who I've spoken and counseled about surgery. And following their surgery, they have been able to come off the drops. And actually, often in the older populations, getting them off these drops are really important, because often there are other comorbidities, or they could be carers for their partners. And that can make their whole life very difficult, because then they have to think about their drops, they have to think about their medications, they have to think about their partners. So, it's a holistic approach. And often as surgeons, we're very fixated on trying to get a problem fixed, but remembering the holistic side of, a patient's outcome is very important.
Related to that, is this type of surgery done under local anesthetic, local with sedation, or general anesthetic?
It can be done with all. For myself and my practice, I tend to try and do majority of these operations under local anesthetic, because it helps with recovery. It helps them be listed a lot faster. In terms of having an anaesthetist, I only need an anaesthetist really for the big aqueous shunts where I'm using the muscles, because when you manipulate the muscles, you can cause a patient's heart rate to sort of drop ever so slightly during the operation. And you just need someone with appropriate expertise to help you should that occur. It happens very rarely, but that's the only time I would want an anaesthetist around.
Quite a long question here I'm going to read out from one of our consultant ophthalmologists at Clinica London, who's also very interested in glaucoma. This is Lisa Jagan. I hope she doesn't mind me naming her. If a patient had a trabeculectomy years ago and their IOP is creeping up again, should we refer back to glaucoma surgeon to see if there is anything to help flow through the bleb, or just restart drops, or a variation thereof?
Yeah, that's an excellent question. So normally when you do a trabeculectomy, if it's within the first 5 years and their pressures are rising because their body's healing and trying to close that valve we created, we can do a very fast procedure where we can break the scar tissue and resurrect that trabeculectomy. But as Ms. Jagan is saying, if it's a trabeculectomy that's been done over a very long period of time, often doing that scar removal isn't going to be as effective. And in those instances, drops can be restarted, or you can refer to the glaucoma surgeon to discuss what drops and whether there's anything else that can be done.
How does all this surgical approach affect the optometrist referring to you? How do they know when to refer to you?
Yeah.
Because someone appear to be quite happy on drops, and it's just creeping up, and it's just very slow progression, optic nerve damage, visual field loss. At what point do you encourage them to refer to consider some of these newer, very beautiful surgical techniques?
I think it's all about education and awareness. So patients may be happy on drops because that's all they're aware of. They probably feel that they have to be happy on drops because that's the only option. So if they are getting worse, I think the key thing for our community partners is to make them aware that there are these other options available and getting them referred in at any point, whether it's the start of early progression, because we can repeat some of these tests here at Clinica and discuss with them that this is your rate of progression, this is how fast things are changing, and you would benefit from surgery at this point or this point, or you would benefit from laser, or you would benefit from continuing drops. But if you're finding the drops are difficult, then we can intervene. So raising that awareness that these options are available is usually the key point. And then the referral can be an open sort of discussion with the patient of whether they want this to discuss this with a glaucoma surgeon. And then you can obviously refer needed.
Can we take any more questions from the floor here at Clinica? Have we exhausted all the questions? Just check. Oh, there's one here, and then there's another online in a minute.
We noticed on the one of the things the patient gave a glowing report of the surgery and the benefit of his life, and he was saying he'd gone back to the gym and doing lots of exercise. I used to go to a gym where a guy used to use some anti-gravity boots for about 5 minutes.
Oh, wow.
Would you recommend this for these patients?
That's a very unique question. It's not something I've had to think about, really. Usually we have quite strict restrictions to begin with. So normally in those first sort of 6 weeks, heavy lifting, doing any even yoga, for example. So doing any positional work that may, even if the risk is small, we just try and make sure that they avoid it just because all that hard work that's gone into it. We don't want anything to reverse the effects of the surgery. Anti-gravity boots, I guess, if they've reached a level of stability, should be okay. I would probably avoid it, to be honest with you, but I couldn't tell you for sure.
Should I ask what anti-gravity boots are?
I think it's to hang upside down.
Really?
Yeah, that's what I thought. Yeah.
Goodness me. Now, I've seen those leggings that compress your legs at the gym, but that shouldn't affect glaucoma. We have another question online. Would this surgery be covered by private medical insurance? Question 1. If it's not private medical insurance, roughly, what is the cost privately? That's a very difficult question,
That
isn't
is
it?
a very challenging question, yeah. So in terms of insurance, yes, all of these surgeries are actually covered by insurance. So if you were to go on the Bupa website as an example of one insurance company, they'll be coded. In terms of privately self-funded, it's difficult to say because there will be facility fees and surgeon's fees depending on exactly which surgery you do. But most often these operations do include the follow-up period as well, and they will vary slightly from surgeon to surgeon.
I think with any cost of any private ophthalmic surgery, there are usually 3 costs. So you have the procedure cost with the surgeon, you have the facility cost by the hospital institution where the surgery is carried out, which covers the theatre and the nurse and all the bits and pieces used in the theatre. And if there is an anaesthetist, even giving the local or giving sedation or a general anaesthetic, that's a 3rd cost.
Yeah.
But I think that it's excellent that it's covered by private medical insurance because it is vision saving, vision preserving,
Correct.
And quality of life giving to the patient. On a different subject here, another question, what difference of RNFL
For the OCT, yep.
Yep, average thickness between both eyes is acceptable on OCT scan. Do you want to read that?
Yeah, I don't quite
We've just
understand
got
that.
it here. What difference?
Of the RNF, average thickness between the two. I don't really know how to answer that. I think when I was talking about OCT, I'm looking at rate of progression, rate of change. So sorry, I'm not really too sure how to answer that, whether you're looking for a
How about sending an email to secretary@clinicalondon.co.uk, address it to Minak, ask the question in more detail, and he'll be pleased to reflect and reply.
Yeah.
I think that's the best answer there.
Absolutely.
Oh, it's time to go home. It must be pretty close to 8 o'clock. I think we will call the meeting to a close. It's been an absolutely lovely evening. We've been, I can come back into the camera. We've been here at our annex of Clinica London, the Clinica London Academy. We've got the balcony terrace doors open. It's a beautiful light evening. We've had delicious little foods, and we've had very interesting conversations before the official hybrid meeting started at 7. And we've enjoyed all your questions, both from the audience here and at home. I hope you've learned something. If you want to contact us, it's secretary@clinicalondon.co.uk, and look on our website, www.clinicalondon.co.uk. And if you want to get your CME points, that will be sorted afterwards. Thank you very much. And
thanks, Jane.
Thank you for a super talk.
Thank you so
much. Really, really good.
Thank you. Thanks, guys. Thank you.
Bye-bye.